Welcome back to the What's in Your Head podcast. I'm Pete Schultz, doctor of physical therapy. Today's episode is focused on migraine and how conservative, non-pharmacologic strategies fit into migraine care. Migraine is not simply a bad headache. It's a neurologic condition involving altered nervous system processing, sensory sensitivity, and autonomic dysregulation. Medications can absolutely play an important role, but many people continue to struggle with frequency, intensity, and disability even when they're taking the right medications. The goal of this episode is to walk through where non-pharmacologic conservative care fits, how we assess migraine as a multi-system condition, and why the approaches that include movement, nervous system regulation, and education can meaningfully change outcomes. This episode is based on a paper that Scott Siverling and I published on conservative migraine management. It's not anti-medication, it's about understanding what else matters, how these systems interact, and how we can help people regain function and confidence. My work with migraine really started working with people who had difficulty recovering from post-concussive symptoms, people whose headaches or they had some post-traumatic post-concussive migraines that just weren't fully resolving, and they kept on having symptoms, and these symptoms were clearly being driven by the nervous system. I was using conservative treatments, and then I started using biofeedback, and we found that biofeedback was really helpful in getting these people to regulate their nervous system. And then we were exploring other psychologically informed practices and different behavioral techniques. And we really were able to help a lot of people in this migraine space. Today, I really want to share that there are approaches beyond medication, and I'm not anti-medication. I work with some really good headache neurologists. There's a lot of really good medications out there, but there's other ways to treat migraine as well. And this is going to really touch on what we do and how we could treat migraine. This episode is really based on an article that I published with a colleague of mine at Hospital for Special Surgery, Scott Siverling. We were asked to do this project. We were asked to create a paper on a physical therapist perspective of conservative care for people with migraine. And we spent a lot of time, and Scott's a great writer, and we really combed through the research and literature and used our experiences with working with people in this area with migraine. And we came up with a nice thing. This article was published July 2023 in Current Pain and Headache Reports, and it's titled A Multimodal Conservative Approach to Treating Migraine, a Physical Therapist Perspective. Oh, it's a great resource, and I've been reached out a lot to by other physical therapists and other healthcare providers in this space when that article was published about biofeedback and some of the approaches that we use for migraine care. So let's talk about migraine. Oh, what is a migraine? A migraine is a primary headache disorder, which means that the headache itself is the disorder. It's not caused by any other disease process. It's not from a stroke or a brain tumor or any other type of disease process. The migraine itself is the disorder. So it's characterized by recurrent attacks of usually intense headaches that last from 4 to 72 hours. The pain is often throbbing or pulsating. It's usually on one side of the face and head, and it's accompanied by nausea, sensitivity to light, sensitivity to sound, motion sensitivity, and motion intolerance. Well, it really reflects altered nervous system processing and sensory sensitivity of the trigeminal nerve pathway, which innervates the head, face, and jaw. Well, it's really a sensitivity to the nervous system. This trigeminal pathway that affects the face, head, and jaw area, usually on one side of the face, gets really sensitive. Those nerves become extra sensitive to any type of sensation, and it results in light sensitivity, photosensitivity, and usually an intense headache. Now, imaging with these patients are typically normal. They appear like if you were to look someone who is having migraine, they usually holding their head or they want to be in the dark. But other than that, they look normal, right? They don't look like there's anything wrong with them. but it's very debilitating. Sometimes it's very frustrating for the individual with the migraine that they look normal and maybe people they work with don't really understand what they're going through and how disabling this is. It gets really frustrating, which adds to the nervous system sensitivity. So now migraines, they usually are accompanied by an aura. Prior to the migraine, you will see wavy lines or spots or floaters or some kind of disturbance in your vision. This usually happens prior to the migraine. And sometimes there's medications that you take when you feel this aura come on. There's certain medications that you could take that will help decrease the intensity of that migraine attack or maybe even stop it. Now, we usually classify migraine if someone has less than 15 headache days per month. Those are typically called episodic migraines. And someone who has greater than 15 headache days per month for a span of over 3 months, that would be into the chronic migraine rate. These are primary headache disorders, but we label them as episodic migraine that would have less than 15 days in a month, at chronic, which is more than 15 days in a month. Migraine prevalence, it affects about 10 to 12% of the U.S. population. That's pretty common for people to have migraine. Over 35 million Americans have migraine, which means about 1 in every 4 households are impacted by this. There's a higher incidence in women than men. It affects 18 to 20% of women and 5 to 7% of men. And sometimes, we don't know. It definitely seems to be, in all the literature, more common in women, but also they do say that women tend to report their symptoms and men are less likely to report their symptoms, which I think is hopefully changing in these times. It's more common during working and parenting years. It usually peaks in your 30s to 50s. And migraine is more common in lower income populations, and there is definitely some socioeconomic and racial disparities. One of the leading causes of disability worldwide, especially under the age of 50, is migraine. There's a lot of loss of work, a lot of disability, a lot of time needed to take off, and it really impacts work, physical activity, and social life, and of course, your mental health. What does a migraine attack look like? Someone who has a migraine attack, there's usually an aura. There might be some wavy lines or some visual disturbance. There is usually unilateral head pain. It's usually on one side of the head or face. It is moderate to severe in intensity, and it's definitely worsened by activity. People if you're having a pretty bad migraine attack, people tend to want to stay away from light, will bother them. They'll want to go in a dark room. They won't want to hear a lot of noise. It's also frequently associated with neck pain, dizziness and vertigo, brain fog, and inability to move or inability to exercise. Migraine affects multiple systems. It's not just a headache. Frequency of migraine really varies. Some women just get them with their menstrual cycle. Sometimes people get them when it's colder outside. There's a lot of triggers. Sometimes there's food triggers. Sometimes there are environmental triggers. Sometimes they just happen. Sometimes people could get migraine once a year. Sometimes you get migraine once a month, 5 times a month. People tend to have normal patterns of these. And it's important to know if your pattern, if the frequency, intensity, or duration of your migraine patterns significantly changes, you want to get a medical evaluation. You want to go to a doctor. You want to go to a healthcare provider just to make sure that it is migraine. And then once the migraine diagnosis is established, then the focus really shifts on reducing frequency, intensity, and duration of these attacks. But when we look at the systems involved with migraine, the first system that we look at is the musculoskeletal system. So the musculoskeletal system is obviously your skeleton, your bones and your muscles, and all the nerves that innervate them. And with migraine, there is a really high prevalence of neck pain. So common findings that we see with people with migraine, they have limited cervical range of motion, limited neck range of motion, limited upper back range of motion. They have postural issues, and they have a hard time sitting up in front of their computer for long times throughout the day. They have poor neck endurance. Their muscular endurance of their neck muscles are poor. Their head doesn't move very well on their neck, and they have TMJ, and jaw issues. Those are some of the musculoskeletal issues we see with migraine. Now, there's also visual and vestibular systems that are involved. Your visual system is obviously your eyes, and your vestibular system is your inner ear and your balance. It controls your balance, and the vestibular dysfunction is very common in migraine. People with migraine are often dizzy. They're sensitive to motion. They have fear of heights. They don't want to go in cars. They don't want to go on boats. They hate amusement parks. They hate rides. So there's definitely vestibular and visual issues that people with migraine tend to have. And these are treatable, which we're going to get into in a little while. So they have issues focusing. They have issues with their balance. They have a hard time going on car rides, boat rides, amusement parks. And there's also something called vestibular migraine, which is a classification where you could get an aura or you could get a migraine that acts similar pattern. It might be 4 hours to 72 hours, and it kind of acts like a migraine pattern, but you don't even have a headache. You experience a lot of dizziness through that time, or you have some vertigo, which is the world spinning. They get really dizzy for several hours or even several days, and then it subsides. It acts like a migraine, similar pattern. We could treat these systems through a multimodal conservative care. Looking at all these systems, so we talked about the musculoskeletal system, we talked about the visual system and the vestibular system. These tend to be the systems really involved. And of course, the nervous system, because the nervous system controls everything. So the way we treat these systems by addressing each system individually, we could use manual therapy. So that's massage, physical therapy, chiropractic. Any of these manual therapy techniques could be used to address neck and mobility restrictions and tissue sensitivity. They could address limitations in the neck and the TMJ and all the musculature around the neck and the shoulders. So now manual therapy alone hasn't been shown to decrease migraine in the literature, but in conjunction with all this other stuff that we're doing, it could be of real help. And then the other thing we do with people who are having migraine is work on their posture, doing posture corrections and showing them exercises to really work on the endurance of these postural muscles. So that brings us to the next intervention, which would be exercise. With the exercise we do with people who have migraine will be endurance training. A lot of times the muscles that hold up your head are weak. So we do exercises like chin tucks and isometric exercises with different bands. And I don't really use weights for these exercises, but it's mostly body weight. And even doing something like a plank or a side plank or resisted chin tuck with a band helps increase the endurance of some of these cervical muscles. And that could be helpful with people who have migraine. Then we could talk about aerobic exercise. So it's really important for autonomic regulation to exercise your cardiovascular system and your aerobic system. We found that people who exercise regularly, it can reduce the frequency of their migraines and reduce the intensity. We also use vestibular rehabilitation with people who have migraine. With vestibular rehabilitation, we're doing balancing exercises and we're doing exercises to acclimate them to things that make them dizzy. And we're doing focus exercise. And vestibular therapy is a treatment. You have to start really slow, especially with people who have migraine because they're very sensitive. And then we build on that and we build up to give them more intense exercises to challenge their vestibular system. Then we'll talk about psychologically informed care. So psychologically informed care, a lot of physical therapists are heading towards, and that's just like understanding mental health, really understanding the nervous system and doing some pain neuroscience education, progressive muscle relaxation, mindfulness and breathwork strategies, somatic tracking, pain reprocessing therapy, meditation, because stress and regulating stress is really important with this population. Then biofeedback. Biofeedback kind of fits into that psychologically informed care, where with biofeedback, we're working on heart rate and heart rate variability, breathing exercises, working on decreasing muscle tension and decreasing the sweat on your hands and increasing hand temperature. We're working on autonomic nervous system regulation and teaching people that they have control over their autonomic nervous system. We could do things to lower their heart rate, to change their heart rate variability, increasing hand temperature, decreasing arousal, and decreasing the sweatiness of their hands, because that's a sympathetic arousal response. So this will ultimately lead to decreasing frequency and intensity and duration of migraine attacks. And then some other things to consider are looking at the TMJ, looking at the jaw and going to a jaw specialist when indicated, some lifestyle medicine, looking at your sleep, your activity, nutrition, decreasing substance of alcohol and drugs. This lifestyle medicine and managing your lifestyle becomes really important in working with migraine. And I always like to think of it as just focus on consistency. Whatever you do and whatever treatment you decide to go on, if you decide to do more aerobic exercise or if you decide to do more self-regulation and breathing exercises, is just be consistent and be flexible, right? You don't have to do 20 minutes of breathing exercise twice a day. Just with whatever you do, be consistent. And 5 minutes a day, 3 minutes a day, 10 minutes a day. There's some new research out there on meditation and self-regulation exercises that just 5 minutes a day of doing some slow breathing exercises could make a huge impact on your nervous system. Well, you don't have to follow all these rules and do breathing exercises for 30 minutes or an hour a day. Just do more than you were doing, right? If you haven't done any breathing exercise or any self-regulation exercises, start with 2 minutes of some light breathing. So we know that 5 minutes a day of these activities are more than enough. Now I'm going to take everyone through a case study. In the article that we published, we put a case study in there from a young woman who was a human resources professional at an academic institution. I believe she was in her 20s, and she had an uptick in migraine leading to a chronic migraine diagnosis. She was having a frequency of headache about 20 days per month, whereas she would have headaches occasionally and migraine occasionally, but in the recent months, she had some stressful stuff going on in her life, and she had an uptick to 20 migraine days per month. She was having significant migraine-related disability. Her primary limitations were exercise intolerance. She was afraid. She had a lot of fear that the symptoms were going to get worse. And she had a lot of reduced confidence in her physical activity. And she was missing work at least 1 day a week for the prior 3 months. My initial findings on her examination showed that she had some cervical spine, neck range of motion limitation. Her neck really didn't move that well. So she had a hard time looking down and turning her head to the right. She also had reduced neck muscle endurance. She wasn't even able to hold her head up. Like when you're doing a sit-up, she wasn't able to hold her head up against gravity. She had significant weakness in her neck muscles. And she had a lot of neck musculature sensitivity. So I wasn't even able to touch the base of her skull or those muscles on the front side of her neck. It was painful just to touch those areas. She also was reporting, since the uptick in symptoms, she was reporting a lot of motion sensitivity. She had stopped taking subways and buses, and she would avoid long car rides. And she was having a lot of dizziness associated with any head or body movements. She had no experience with any self-regulation exercises. She had never done any breathing or meditation. And she had what I would consider poor physiologic autonomic nervous system regulation. She wasn't able to regulate her nervous system well. She had a hard time down-regulating. Once she would get symptoms, she had a hard time coming out of them and functioning out of those symptoms. We started a multimodal treatment approach with her. Right. From what I remember, she didn't want to take medications, or she was very limited for some reason on the medication she was able to take. Oh, her neurologist has sent her to me to work on some non-pharmacological treatment of migraine. What we did first, or what I did first with her, was education. So we did a lot of neuroscience education, which I've addressed a lot on this podcast before. We talked about migraine as a nervous system hypersensitivity, talked about how the nervous system works with regards to pain. And remember, I went right through that neuroscience model of pain, the danger safety model. I explained to her, when you step on a nail, you have all these sensors in your foot, and those sensors send information to your spinal cord, and that sends information up to your brainstem. And in your brainstem, there's an alarm box that goes off, and that alarm box then goes to the cerebral cortex, and the cerebral cortex has to determine if this situation is safe or dangerous. And then it goes to the prefrontal cortex, and the prefrontal cortex is an area in your brain that helps you make a decision whether the situation is safe or the situation is dangerous. And if there's more credible evidence of danger than there is credible evidence of safety, then your nervous system is going to create pain to protect you. We talked about how pain is a protective mechanism from the brain. And just like stepping on a nail, your brain is trying to protect you. When you get a headache, your brain is trying to protect something. And the fact that you have been getting these chronic symptoms, that you have a lot of practice at this, and this system is getting more trained and it's getting more sensitive, and your nervous system thinks it's doing a good job. It thinks it's doing a great job protecting you by creating this headache to make you aware. Even though there was nothing structurally wrong on her MRI, there was no tumor, no aneurysm, no blood vessel issues. She had significant headaches because her nervous system was trying to overprotect. Then after the education component, where I spent a lot of time explaining the nervous system and having her understand the nervous system, we started some biofeedback assisted relaxation. Well, what I usually do there is we started with an assessment of her autonomic nervous system by doing a quick assessment protocol with biofeedback, using technology and equipment to measure heart rate variability, respiratory rate, muscle tension, finger temperature, and sweat on the hand. We could use this technology to measure all these metrics of the autonomic nervous system. And we know when the autonomic nervous system goes into the sympathetic reaction, or it goes into fight or flight, your heart rate increases and you breathe faster and your muscles get more tense and your hands get cold and sweaty. We could measure all those things. What I typically do on the first biofeedback assessment, we do a baseline and we measure all of these metrics at baseline for 2 minutes. And then I give someone a math task. I have them, let's say we'll start at 100 and we'll subtract 7 from 100. That's 93, and subtract 7 from that. I give them some math tasks. That's called the serial 7 test, and math usually stresses people out. And then we're going to measure their nervous system and how it responds to stress with a math task. And then we do that for 2 minutes. And then we have them rest and breathe for 2 minutes. And then the next 2 minutes, I would have her think about a stressful memory. Something recently that happened was really stressful to you. Think about that for 2 minutes and see what that does to the heart rate, breathing rate, muscle tension. And then I have her try to, for the last 2 minutes, try to downregulate and do some breathing. And then we kind of see how how her stress response was and how she gets out of that stress response. So then after doing that, I started with some breathing patterns. While I was measuring her biofeedback, or while I was using the biofeedback technology, we would do breathing patterns, and I would have her breathe in for 4 seconds, out for 6 seconds. Or do some box breathing where you breathe in for 4 seconds, hold for 4 seconds, breathe out for 4 seconds, and hold for 4 seconds. And you do that for several minutes. And then I would measure, see if her heart rate would go down and see how her autonomic nervous system responded. We also did, throughout the different treatment days that I saw her, We did some visualization. Close your eyes, visualize yourself walking on a beach or walking in the woods in nature somewhere where you really enjoy going, and then talking through some visualizations and see if that causes the hands to get warmer or causes the heart rate to reduce. We use some visualizations, breathing patterns, some meditation, and all while monitoring her heart rate variability, heart rate, muscle tension, finger temperature, and her arousal, which is sweat on the hands. Then we did some targeted manual therapy. Targeted manual therapy, working on those sensitive muscles that are at the base of the skull, the suboccipital muscles, and the SCM muscle, which is on the outside of the side of the neck where you take your pulse. So we did some light massage on those areas, a little bit of traction on the joints of the neck, some massage of the muscles around the jaw to help address the mobility restrictions and the limited range of motion. Throughout her treatment, we also started cardiovascular exercise. We did some graded cardiovascular exercise training, starting with 10 minutes on a stationary cycle with a low heart rate in that zone 2. Her heart rate was around 120 beats per minute for 10 minutes. And then I would have her go for walks outside. And we gradually increased that over time. And outdoors, she was measuring steps. And we progressed her cardio program to 30 minutes, 5 days a week. She was able to tolerate more exercise throughout our treatment. Then we did some cervical endurance training and posture retraining. I had her do a lot of exercises for her postural muscles and her cervical muscles. Like I said before, she had a hard time holding up her head against gravity. We did some isometric strengthening of those muscles, and we used the TheraBand to help strengthen some of the muscles of her neck and her posture. Following this multimodal program, her migraine frequency reduced to fewer than 5 days in a month. She was in for 8 visits over the course of a few months. And after those sessions, she went from having 20 headache days per month to 5 headache days per month. And that lasted for at least 3 months afterwards. She had significant improvement in all the migraine disability questionnaires. She returned to regular aerobic exercise, including running, and she even signed up for a 5K road race in the months following the program. She was on a regular self-regulation program that changed between paced breathing patterns and different guided meditations. She was doing something every day. And that something ranged from 10 to 30 minutes. So sometimes she would do 10 minutes of a breathing exercise. Sometimes she would do a 30-minute guided meditation. But she would change it from day to day. But she was doing something every day to regulate her nervous system. And she hadn't missed a day of work in the past 3 months due to a migraine, which was like the greatest outcome for her. Again, she still had some migraine, but going from 20 migraine days a month to 5 migraines a day a month is fantastic. And not missing any days of work is huge. This demonstrates how migraine is influenced by multiple systems. We have your musculoskeletal system, obviously your nervous system, your visual system, your vestibular system, your cardiorespiratory system. All these systems are involved in migraine. It's not just a headache. And it's really important to get an assessment from a qualified healthcare professional, someone who is versed in treating people with headache and migraine, to really get an assessment to make sure there is nothing seriously medical going on. And then you could go and really try to focus on decreasing the frequency, intensity, and duration of these. Now, the evidence out there strongly supports conservative non-pharmacological care as a meaningful component of migraine management. And sometimes people just don't want to take medication, or they don't want to take more medication, or they can't take medication, or for some reason they're unable to tolerate it. Just everyone knows that there are treatments out there that aren't medication that could really help be a good adjunct to your care and decreasing the frequency, intensity, and duration of these migraines. So the key takeaway is migraine is a multi-system nervous system condition, and it's not just a headache. Conservative care is most effective when it's individualized to the person and it's assisted by a qualified healthcare professional. And really, the patient needs to be in the driver's seat. Patient with migraine needs to be an active participant in their care. And I can't emphasize this enough, that the people who get better, they have to be in charge and you have to steer the ship. And if you're someone who is having a lot of migraine and you're just going somewhere and having someone massage you and just going somewhere and just taking a meditation, it doesn't have to be a passive approach. You could be an active participant. You should be moving. You should be exercising. You should be out there doing things you want to do. There are things like breathing exercises and meditation. There are things that you could do to improve your situation and improve these headaches. And long-term relief from migraine is possible with and without medications. Like always, this podcast is for educational purposes only, and it's not individualized medical advice. If you are experiencing, especially an uptick in your migraine symptoms, you should be working with a doctor or a qualified medical provider. If you would like more information, a physical therapy assessment, and you're having migraine, you could go to dynamicsportspt.com for a physical therapy and vestibular therapy assessment and treatment. And you could go to Pain&Dizzy.com for some education and self-management tools. Well, it was really fun talking about migraine today, and I will see you next time.